So ARUBA study has had a very important impact on our clinical practice of every day, and we treat much less AVM by embolization than we were doing before. So it has had a very important impact. It's a kind of flow, and since ARUBA has been published, it's difficult to treat unruptured AVM because of the very poor result of ARUBA. So it has had a very important impact in every situation. I mean, embolization, surgery, and radiosurgery. In my team, in my hospital, we do the three of them. And we do treat much less patients, whatever the technique, since ARUBA. The other impact of ARUBA, and this is very surprising for me, is that there are two papers in the literature from the US showing that since ARUBA was published, there are much more patients coming to the hospital with a ruptured AVM and much higher in hospital mortality, as if the fact that we don't treat anymore by embolization surgery or radiosurgery unruptured AVM makes that you have much more AVM coming, patient coming with a ruptured AVM in the hospital since ARUBA. So this is the bad impact, the sad impact of ARUBA on the risk of rupture of brain AVM. It's really difficult to understand these two papers. I was extremely surprised when I saw the result of this paper showing that ARUBA has had a bad impact on patient care. Yeah, so there is a very good paper which has been presented in SNIS about the Cleveland Clinic experience, which has confirmed a lot of publication about surgery, about radiosurgery, or even embolization of brain AVM, showing that in reality, in real life, results are much better than in ARUBA, in which the results were horrible. And so it's true, it's sure today that the result of any kind of treatment is ARUBA is much worse than what we see in the real life. So since ARUBA, there is no other randomized study, and the only large study is TOBAS. TOBAS combine registries and two randomized arms. So there are registry of not doing anything, surgery, radiosurgery, embolization, and you have two randomized arms, which are if you treatment versus no treatment, and if you select surgery with embolization before or not. And it's a very, very large study with almost 2,000 patients, I guess. And recently there were two papers published, one showing that embolization is not good. In TOBAS embolization registry, you have 9% morbidity and only 30% of patients got a complete occlusion by embolization alone. And I was in charge of the Onyx study by Medtronic, which results are going to be published soon, and which are much better because the morbidity is around 4-5%, and you have almost 80% complete occlusion by embolization alone. So if you look at the result of TOBAS, you may say embolization is dangerous and not efficient. If you look at the Onyx registry, it's much more positive. You have much less morbidity and much better result in terms of complete occlusion, obliteration of the AVM. Since a few years, more than 5 years at least, every time you go in a congress, you see someone presenting the venous approach of brain AVM. And this is very, very attractive, very promising technique. So we see a lot of cases presented, but we have no data. And so for me, it's very difficult to know what is going to be the future of a brain AVM treatment by venous approach. Probably it's much more efficient, but in my opinion, it's probably as well much more risky. And there is a study, which is TATAM study, which is a randomized study on brain AVM venous approach. And I think that we need to have the result of this study to really understand what is going to be in the future the role of the venous approach compared to arterial approach or on the other technique, surgery, radiosurgery, other thing.